Look at this split screen. On one side, a sparse, hastily written sentence on a clinical chart. On the other, a formal legal subpoena. In nursing, documentation is a vital legal shield. The standard is strict. If an intervention isn't documented, legally, it didn't happen. When adverse events occur, auditors and legal teams look directly at the patient's chart. They are searching for clear evidence of clinical judgment. Your notes need to show exactly how you evaluated the patient and escalated care to protect both the patient and your license. This graphic displays the golden rule of documentation, paired with warning icons for time delays and medical errors. The rule is straightforward. A clinician who was not present must be able to read your note and understand exactly what happened, the patient's status, and why specific decisions were made. There are two major risks that compromise this rule. The first is delayed entries. Writing notes hours after an event occurs degrades the accuracy of the information and strips the record of its legal validity. Notes must be contemporaneous. The second risk is preemptive charting and the use of unapproved abbreviations. Documenting an intervention before it occurs is falsification. Additionally, shorthand like a capital U for units or QD for daily are direct catalysts for medication errors. Adhering to real-time, accurate charting protocols creates a factual timeline. When done correctly, a clinical note acts as undeniable proof of care. We often hear clinical shorthand on the floor, labeling a patient as difficult or calling someone a frequent flyer. In a legal context, these terms immediately introduce bias into the record. This two-column chart illustrates the required shift in thinking. To protect the integrity of the chart, you must replace every subjective label on the left with observable, measurable clinical data on the right. Take a vague phrase like "wound looks worse today." To record this objectively, you report the exact data. The record transforms to read, Stage 2 pressure injury, measuring 2 by 3 centimeters, with 50% slough and 50% granulation. When dealing with pain, refusals, or specific patient concerns, use direct quotes. Writing exactly what the patient stated, enclosed in quotation marks, entirely removes your personal interpretation from the record. Systematically removing your own bias, opinions, and assumptions leaves behind a concrete timeline. You create a legal record that relies purely on clinical evidence. To structure this objective evidence, we rely on a specific standard. The ISOBAR framework is the required structure for all handovers and significant progress notes. Here is a vertical breakdown of the ISOBAR acronym. The I stands for identify, recording the patient, clinician, and current location. The S is the situation. This is your immediate headline, indicating exactly why you are writing this note right now. Next is O for observation. This section must contain current vital signs and your objective assessment findings. Then we move to B for background. This is where you document relevant medical history and any comorbidities that impact the current situation. Notice this visual boundary separating the S and the B. A very common trap is mixing up the situation and is the historical context leading up to it. Finally, A is the agreed plan, detailing your next steps, and R is readback, confirming who was notified and who holds responsibility for the subsequent actions. Applying this rigid framework every time guarantees that no critical information slips through the cracks during transitions of care. Let's apply this to a high liability scenario. Look at this mock chart for our de-identified patient, Mr. Smith. He has a new skin tear on his arm, and he is angrily refusing to use his pressure-relieving mattress. Documenting that a patient refused care is not enough to protect you legally. To prove you delivered safe care, the note must include your clinical rationale and the specific education you provided to the patient regarding their refusal. Take a look at this legally poor, highly subjective draft note. Mr. Smith is being non-compliant and refuses to turn. Pause the video here and rewrite this sentence objectively using the concepts we just covered. Explicitly documenting the why behind any deviation in a care plan is the difference between acting as a passive scribe and practicing as an active, legally protected clinician. Watch as we build the correct observation section for Mr. Smith. We replace the label non-compliant with the exact time of refusal and insert a direct quote. Patient declined repositioning at 1400, states, "I am comfortable." Next, we populate the agreed plan and readback sections.
We write, educated patient on pressure injury risk. PM shift charge nurse notified of refusal. This completed note is bulletproof. It utilizes the ISOBAR structure, strips away all subjective labels in favor of quotes and objective data, and clearly proves that clinical judgment and education were applied. This cheat sheet breaks down the 3 pillars of defensive documentation. 1. Rigidly use the ISOBAR framework. 2. Document only objective data with direct patient quotes. And 3. Eliminate pre-charting and unapproved abbreviations entirely. High-quality documentation requires exactness. By mastering these objective, structured charting principles, you provide the ultimate proof of delivering safe, high-quality patient care.